Hello, welcome to this NMC OSCE tutoring video. My name is Hannah. I'm a UK registered nurse, a university lecturer, and I've been an NMC OSCE programme lead in the past. And I provide one-to-one private independent OSCE tutoring for international nurses. And on this channel, I share hopefully lots of helpful information and advice to support you with your NMC OSCE, but also your nursing knowledge, which will support you in your UK nursing jobs as well. So today I was going to look at re-evaluation times for care planning. So this is a common theme and thread that I get some questions on the YouTube channel, but also I see in a lot of these OSCE forum groups around what re-evaluation time should we put for certain care plans. It's also a common area of fail for care planning because we haven't put an appropriate re-evaluation time. So I'm going to look at what we mean by re-evaluation times, key questions to ask yourself when you're thinking about your re-evaluation time. So instead of just trying to memorize different re-evaluation times for different care plans, if you understand why you're doing it and what those re-evaluation time means and what questions you need to ask in order to get to the right answer, then it won't matter what care plan you're doing, you'll be able to get this correct, okay? And that's also important, not just for your OSCE, but moving forward when you are registered nurses. Planning care is a massive part of the NMC standards of proficiency and a big part of our practice as nurses. So in this video, I'm just going to look at the re-evaluation timeframes in relation to your care planning station. I've got another video which talks about the care planning station in more detail and looks at the difference and how we write problems, goals, aims, interventions. But I'm specifically focusing on the re-evaluation times in this video. So just to very briefly recap that care planning station. So you've got 14 minutes to write your 2 care plans relevant to your patient assessment information that you've gathered in your assessment station. And remember, a care plan consists of 4 kind of major components. One is identifying a clear and relevant problem. The other is identifying a clear, measurable and specific goal or aim. Okay, so to get that patient back to a normal state. And then the third part is documenting a re-evaluation timeframe. Okay, so when you're going to come back and reassess your problem to see if you've reached your aim. And then you've got your series of nursing and patient interventions to help reduce your problem or achieve the aim. So re-evaluation timeframe is often an area of uncertainty. Like I said, I see lots of questions about this in various OSCE forum groups, and it can be a cause of failure in your planning station if you put a inappropriate re-evaluation timeframe in your care plan. So what is re-evaluation? So re-evaluation is the process of assessing the effectiveness of your implemented care plan. Okay, so it's going back and reassessing, and seeing, have you reached your aim? Okay, so have you met your care plan goal? And you're also at the same time assessing if your interventions have worked or assessing if they haven't worked and whether they need changing. So why is it important? So it's important because it ensures your care plan remains relevant to the patient's condition, okay? And it promotes timely adjustments to meeting changing needs, okay? So it reduces the risk of us doing interventions which aren't necessary, and it also reduces the risk of harm to the patient, okay? So for example, if a patient was in pain, we'd want an appropriate re-evaluation timeframe so that patient would be left in pain and not reassessed for a number of hours. That would cause risk and harm to the patient, okay? So there are different factors influencing your re-evaluation timeframes, and this is a really important concept to understand when you're looking at your NMC OSCE care plans, okay? So timeframes will vary. They will be different for a patient with an acute condition versus a more chronic and long-term condition. The timeframe again will be different if we are writing our care plan for the hospital setting versus the community or home setting. The goals of the care plan as well. So are they short-term, for example, something like your pain relief, or are they long-term, so maybe rehabilitation or nutrition potential care plan? And our intervention type affects our re-evaluation timeframe as well. So are we looking for something which is going to have quite immediate outcomes, such as assessing medication effects, or are we looking at something which is going to have a more longer, gradual outcome, for example, like your wound healing or increasing somebody's weight and reducing the risk of malnutrition, for example? So these are all things you need to be thinking about when you're writing your care plan, yeah? Are you writing it for an acute condition, a long-term chronic condition? Are you writing it in a hospital setting, in a community setting? Is your goal something that you would want to be resolved in the short term, okay? Or is it more of a long-term goal? And what type of interventions are you putting in your care plan? Are the ones which have immediate outcomes that we need to measure, or more long-term ones? So when I teach care planning to my tutoring students and we talk about reevaluation timeframes, it always comes up a lot. There are like key questions you can ask yourself, okay? And this will really help you identify the correct reevaluation timeframe. So firstly, a really good question is, how long would I leave that patient with that problem before I came back and reassess them? Okay, so a really easy example of this is pain. Yeah, if I've got a patient in severe pain, I'm going to come back very quickly to reassess them. Most probably 30 minutes until I'm not going to leave a patient in pain for 2 hours, 4 hours, 6 hours a week. Okay, so that's a really good starting question if you're thinking about what that time frame needs to be. Okay, if I was assessing a patient who had more long-term slow healing wound, I'm not going to see a change in 30 minutes. That wound's going to look exactly the same as when I last reviewed it. So my reevaluation time frame could be, 48 hours, 24 hours, could even be a week. Yes. So that's like a really good question to be asking yourself. And then you can also ask yourself, like, when would you expect to see a change? Okay. So the interventions that I put down in my care plan, when would I expect to see them making a difference to the patient? So that can help you, can be a good prompt. The other questions to ask is there any evidence that supports your reevaluation timeframe? Okay, so for example, I could draw on NICE guidelines, I could draw on the News 2 policy to support my reevaluation timeframes. A really important question is it safe? If I left this patient with this problem for this amount of time, would they be safe? Okay, would they come to any harm? So that is a really important question. And another question you can ask yourself is, can you provide a rationale for your time frame? Okay, so I can provide a rationale for coming back and checking my patient every 30 minutes, okay, who's got severe pain. Firstly, I wouldn't want to leave them in severe pain longer than that because that's going to cause them harm, okay. Secondly, I know that most oral medications, analgesics I'm going to give, can take approximately around 30 minutes. It varies on different, patients, how they respond to those, but I'd expect to see a change in 30 minutes, okay? And if I didn't see a change in 30 minutes, I'd be escalating that up and getting some additional treatment, okay? So I can really clearly justify my reevaluation timeframe of 30 minutes for pain. So those are really key questions to jot down. And when you're thinking about writing your care plans, these are questions you should be asking when you're deciding what should that reevaluation timeframe be. So let's look at some acute conditions then. So at the beginning, I said that, it depends if we've got an acute condition or a chronic condition. It's going to influence our reevaluation timeframe. So I've just talked about pain quite a bit. Pain is a very common problem in your NMC OSCE. So again, I'll just ask myself some of these questions. So how long would I leave a patient in pain before reassessing? Maximum of 30 minutes. I wouldn't leave them any longer than that. Okay. I wouldn't want my patient to be in severe pain without me intervening and doing something further. When would I expect to see a change? I would expect to see a change maybe within 30 minutes if I've given some analgesic, okay? So a reevaluation timeframe for a pain care plan would be 30 minutes, and I can support that, okay? I've got rationale for it, and it's a reasonable time, okay? I would not want to be leaving this patient 4 hours or 6 hours in severe pain. Let's look at another acute condition, so shortness of breath. Again, a common care plan that can come up. You've got a pneumonia scenario, asthma scenario, end of life scenario, chronic heart failure scenario. They could all potentially have shortness of breath. So if I've got someone with shortness of breath, how long would I leave the patient before reassessing? Again, depends on the severity, possibly 30 minutes to 1 hour. Okay, when would I expect to see a change? Or, maybe start that patient up, administer some oxygen. I might expect to see a change maybe within an hour, hopefully, okay? But again, with these ones like shortness of breath, maybe you're not quite sure, 30 minutes or an hour, what would be good? What can support our decision making? So our News 2 monitoring policy here really supports our decision making, okay? Because we know in that News 2 monitoring policy, if they are scoring 3 in a single parameter, okay? So if that respiratory rate is increased and it is scoring a 3, then the monitoring policy is 1 hourly, okay? So it would be absolutely fine and safe to put our re-evaluation time frame as 30 minutes, okay? Or equally 1 hour. Both would be safe and both would be kind of justified and rationalised. Another acute condition, so could be dehydration. Maybe our surgical patient is not mouth, got nausea and vomiting. Again, could be quite a common problem in your OSCE. So again, how long would I leave a patient before reassessing? I mean, I'd most probably would be checking on the patient every hour. They've got quite severe dehydration. I'd definitely be updating that fluid balance chart hourly, seeing what's coming in, what's going out, okay? So I can justify the re-evaluation time frame of an hour, okay? And also in this situation, I could have potentially 2 re-evaluation timeframes, not to cause you confusion, but I would be re-evaluating the fluid input and output hourly, and then the overall fluid balance, like every 24 hours. Again, is it safe? Yes. Can I justify it? Yes. Is it reasonable? Yes. So you can see with these acute conditions, the timeframes are normally a lot shorter, okay, because of the acute nature of the problems that you've identified. The higher the risk there is to patients, okay, especially within the hospital setting. Again, another acute condition is our risk of neurological deterioration with our subdural hematoma patient. That could be our problem. So again, how long would I leave a patient before reassessing their GCS if they've got a risk of neurological deterioration? Well, if their GCS is 14, I'm going to be reassessing that every 30 minutes, okay? What supports that decision? So again, this is where I can draw my NICE guidelines to head injury management. So the NICE guidelines stipulate that we monitor and GCS every 30 minutes if the GCS is 14 until it reaches 15. Okay, so I can support that decision making. So my re-evaluation time frame, if my problem was risk of neurological deterioration, would be 30 minutes. Can justify that, it's safe and it's evidence-based. What if I got some more in-hospital conditions, but they're not so acute? Okay, so maybe my post-operative patient, we've got a problem of the risk of wound infection, or we've got a care plan to promote wound healing, for example. So again, how often would you be reviewing that wound and assessing that wound? Well, I'm not going to be looking at that wound every 30 minutes, am I? Not very little is going to change in that time period. But I might be reviewing that wound firstly, every 24 hours post-op, and then maybe moving on to a little bit longer, so every 48 hours to 72 hours. When would I expect to see a change in the wound healing? Again, not going to really see any change in that wound in those very first few hours, okay? So again, something like 48 hours to 72 hours, I'm going to might start to see changes in that wound and potentially any signs of infection, but also start to see, the wound improving, inflammation going down, especially within that 3-day mark. These kind of non-acute ones, but in hospital, can have a longer time frame, okay? So my re-evaluation time frame, so I could put 24 hours. That again is safe and I can justify that, okay? And I could even put a little bit of a longer re-evaluation time frame of kind of 48 hours. We're not disturbing wounds really regularly now. We don't kind of do that in practice. Okay, so both would be safe and we could justify both. Another in-hospital non-acute conditions, potentially pressure damage, risk of pressure damage, which all our patients are at risk of. Again, thinking like how long does it take for pressure damage to occur? Well, it can occur very quickly. So 20 to 30 minutes, pressure damage can occur. But when do we often reposition and check pressure areas, within our nursing rounds? So at least 2 hourly, we are promoting that patient to move, change positions, or we are assisting them kind of every 2 hours. So when would we be checking the skin? With those interventions and with moving the patient, so at least 2 hourly. So a re-evaluation time frame of every 2 hours, pressure damage, again, is justified, supported by pressure area care and movement and turning of patients every 2 to 3 hours, so we can support that decision there as well. So if we go on then to look at community conditions, so obviously think about your community conditions, they're normally long-term and they're not acute, okay? And you are unlikely to reach your goal in a short period of time, okay? So not like in your hospital ones, you're not going to reach your goal quickly, okay? And you're unlikely to be reassessing that patient frequently, okay? Within the community nursing and community conditions, especially in your NMC OSCE exam, you're not going back to visit that patient every 30 minutes, for example, okay? It's just not going to be possible. And again, it's not needed because of the problems that you are going to identify. I mean, this is a common one. Long-term conditions is impaired memory is a problem in Alzheimer's. So if we just think about this, you know, supporting someone with impaired memory in the home actually is quite a significant problem and takes a lot of multidisciplinary work, approach with different professionals. We might be adding adaptations to the home and additional additions of equipment or support in the home. So this is not going to happen quickly, okay? This is definitely not something that we're going to see a change in 30 minutes or an hour or even 24 hours. This most recent we're going to be reviewing like weekly, okay? So again, thinking about that outcome, thinking about what's involved, thinking about what changes you need to put in place. So we can have a wound as well in the community setting, okay? And again, if you think about this, the difference between this type of wound and an acute surgical wound is that this is a chronic wound. Yes, the patient most probably had it for a long time, okay? So we, again, unlikely to see any changes in the short period of time. But there's also a lower risk. So there's a lower risk of infection because the patient's at home, you know, in their own environment, okay? Risk of infection in hospital is much, much higher, okay? Which would support a more frequent observation than you do in the community, okay? And again, a lot of these slow, long healing wounds, you know, you're not going to see a dramatic change. Even if we think about changing dressing and changing treatment, we need to give that time before we can see any significant changes. So again, a wound in the community would be very reasonable to be reviewing that every 7 days and weekly as well. Risk of malnutrition and weight loss. Again, this is common in the community scenario. And, you know, I'm not going to see a dramatic change in the patient's nutritional status or their increased weight, okay? This is not going to happen over a short period of time. Now, if I'd ask the patient to keep a food diary, I might be reviewing that weekly. And, you know, what supports our decisions? So the MUST guidelines, so support there around frequency of when we weigh, when we complete the MUST assessment again. So something like malnutrition and weight loss in the community setting, our re-evaluation timeframe, you know, would be weekly, okay? And in some cases, you know, even monthly, you know, we'd be looking at this over the long term. So what are my top tips with re-evaluation? So firstly, think about your problem, okay? Try to avoid just getting a list of problems and a list of timeframes of people, okay? Really think about what your problem is. Ask yourself these key questions. So how long would I leave a patient with their problem before I came back and assessed it? When would you expect to see a change or improvement, okay? And what evidence supports your re-evaluation timeframe? That's really important because we must demonstrate being evidence-based in our nursing practice and in our NMC OSCE exam. Is it safe? Okay. So leaving that patient for X amount of time with this problem, is it safe for the patient? And can you provide that rationale for your timeframe? I hope that's helpful with your care planning. Get quite a few questions on that. Again, I'm available for one-to-one tutoring. Got excellent pass rates for my full tutoring clients, but I do a lot of support for research students as well who have studied elsewhere. So feel free to email me. I'm taking bookings from January. I'm fully booked up almost now for November. Well, for November I am, and most of December. But feel free to email me on hannah.lames@outlook.com. Please like, subscribe, and share my videos if you think they will help anyone else in their OSCE preparation.